Okay, well, good afternoon, everybody. Once again, I'm Chad, coming to you guys from UW Oshkosh. I've been affiliated with the group here for, I don't know, about 4-ish years. Jason, thank you for the invitation to come and present today. So this specific paper, the relationship of opioid prescriptions and educational performance of children. This is actually a published paper. It's published about a year ago. I'll let Jason know that. He was like, "Nah, I want you to talk about it." I'm like, okay, fine. This is co-authored with John Gordnier and Orville Osterk. All three of us are Badger alums, so they say hi. I don't do a lot of things with opioids. I'm a health economist. I teach opioids in my class, but Orville has done more. And the three of us were at a conference in the before times. I don't remember exactly how long, but in the before times it was. But we were at a conference, we were in a session that was on opioids, and at the time, we were doing research on a paper that was looking at SNAP timing and educational performance in South Carolina. So we had this data, and then the session was going on, was talking about a lot of home instability caused by the opioid epidemic in the United States, and it got us thinking after the session was over maybe a couple beers or wine or some other things, about kind of the data we had and some of the issues that might spill over onto children from the nature of this opioid epidemic. And so that's where that was kind of the maturation process for this paper. And I should point out right up front, we don't have a causal identification strategy. It's really more of a statistical association that we're looking at because you just don't really have the data or the exogeneity to really get that far with it. So, all right. So I think, for those of us who talk about opioids or teach opioids or do research in this area, we're all pretty familiar with these trends. So the histogram here shows us opioid prescriptions from 2000 to 2017, which is the end year for the period that I'm looking at here with this research investigation. And then we can see overdose deaths involving opioids, and this is the common prescriptions is the red line, and then we've got the other synthetics and heroin and things that come later when kind of the curbs went in on opioid prescriptions around the 2012-13 period. But we know that there's been this dramatic growth, right? And the kind of communities and demographics of people who have been hit hard by this are often identified descriptively as being people in their 30s or 40s, white communities, rural communities, but ages that typically have children. And so we started thinking when we saw some of this background research, it provided us good motivation that we wanted to consider the possibility that opioid abuse and the opioid epidemic could have spillovers onto children's educational performance. And what kind of got us motivated on this was we saw some of the research about some of just the scope or numbers of children that are affected, right? So number of children who are living with a parent that abuses opioids. There are estimates that range somewhere from around 550,000 to as high as over 800,000 kids who are living with an opioid abusing parent, not just somebody who's on opioids, but actually in an abuse state. And these are numbers that come from kind of the height of the prescription epidemic period, 2012, 13, and 14. And so given that parents that abuse drugs are much less likely to kind of meet the basic needs of their kids, I don't think it's a stretch to think that these kids might struggle in school. We look at living arrangements. There are several papers that document the relationship between opioid use and children being removed from their homes. And Buckles, Evans, and Lieber have this paper that estimate that due to the drug crisis, 1.5 million more children are living in a household away from their parents. So that there's this instability effect at home. Lots of kids being affected, major instability, and then there may even be spillovers in the classroom to kids who are not actually in households that are acutely affected. So that there may be kind of these community level effects, since we know opioid abuse tends to get clustered in these areas. So there's a lot of anecdotal evidence that teachers in these areas are spending more time and effort and resources just trying to meet the basic needs of these kids. And I don't think it's a stretch to think that if teachers are asked to bear more of the brunt of that, there could be actual just generalizable negative consequences in the classroom. So it was with that background that we came to this kind of research question, which is there evidence that opioid abuse has these negative spillovers on the student performance in schools within communities that are most affected, right? Do we see any statistical associations consistent with that story? And so the data we had at the time is this really great administrative student data from the state of South Carolina for 11 years between 2006 and 2017. So it's administrative student panel data. It's all 3rd through 8th graders in the state of South Carolina. We got it from their Department of Education. And it provides us the standardized test scores in math and in English language arts, although in this paper we focus on mathematics for these kids. And so, I don't know what's going on with my formatting there. Huh. I don't know. 20 as 06 is apparently a year now. Anyway, so the pre-admissions content test is the test that they used in South Carolina prior to AY09. And so we've got 3 years of that data. And then starting in the academic year 8-9 through 17, we've got the Palmetto Assessment State Standards Test. So this is a test that's given in May. All the students in South Carolina take the test. And it's just, your standard grade year level kind of exam to see how students are progressing. And so we've got the test scores for all of these kids, and we can track them over time. We have their race, their gender, characteristics of the school they go to, and then we were able to get it linked with the Department of Social Services data to whether or not the students families are participating in SNAP and or TANF at the time that they took the exam. And that there was like I said, a different paper that utilized that information, but we can use that as a like individual level control as well. And so what students do we have? We have all the students in South Carolina during this 11-year period who were receiving SNAP at the time they took their exam, and then a 65% sample of all the non-SNAP students for this 11-year period of time too. So it's a big data set. There were 2 million student observations, about 750,000 unique kids, right? And so when thinking about opioids, one thing you might want to do for an identification is you might want to say, okay, if we have some exogenous reason that opioids are going to be prescribed, it'd be great if we could look at the households that are actually getting those prescriptions or actually measure the degree of prescription, say these are the abusing households, and link those up to those kids. Now, we don't have that information. So we do is we kind of took a community level measure, and we said, well, what we do have is we can look at county opioid prescription rates. So there's about there's 46 counties in South Carolina. We can look at the time variation in location and time in prescriptions and look at kind of like county treatments. It's not as good. And then we can also, so we can look at the effect of that on these individual performances and then also kind of these county measures and try to see if there's kind of this association present. So the county data that we utilized, same time period, and it comes to us from the CDC. It's based on a sample of about 50,000 retail non-hospital pharmacies. They make up about 90% of all the retail prescriptions in the state. And so kind of like our community treatment variable is going to be the number of prescriptions per 100 people in a county per year, right? So it's just a per capita measure. And there's a lot of variation in it during this time period. So the lowest measure is 23 per 100, and the highest is 177 per 100. And then basically, if you look at the counties, they mimic the country in a lot of ways. They basically drift upwards during this period of time. They're not, some of them accelerate, the growth rate is much faster than others. Some are at a very low level and kind of stay at a low level, like Saluda County is low and it doesn't really move very much. Some are at a high level and don't move very much, like Spartanburg County is a lot of prescriptions at the start of the period and they don't really change much. But most of them grow, but the rate of growth varies from, 30–40% from the beginning to the peak, and others 100%, 110% growth in prescriptions per capita during this time period. And so we've got all the counties but 2, Calhoun and McCormick, for whatever reason, we couldn't get all the data, so we just dropped those. So we got 44 counties we're looking at here. And I should point out that in South Carolina, where I used to live, South Carolina's not a massive geographic state, but it has a lot of counties because it's an old state, and the counties are relatively small, right? So there's a lot of heterogeneity with between counties, but not so much within a county. Okay, so we're unable to link. Oh, Bobby, go ahead.
I just want to go sort of explore what you're thinking, because there are counties that have individuals that have events happen to them more commonly, for which opioid prescriptions would be appropriate.
Yes.
Right?
Yep.
And so these presumably differ by county as well. Some people are more exposed to the risk of all kinds of physical accidents. So when you think about this, how do you differentiate those that have a legitimate and usually short-term reason for a prescription versus those where your thought really is for people who presumably are kind of addicted and it's long-term or problem with you.
Yep. And so, well, we're gonna, for places where we think it's a persistent reason, we're gonna have county fixed effects. But as I go through it, I'll try to say, well, I'll try to show you what we did to try to make it more, to provide more confidence that the statistical association isn't driven by some kind of unobserved factor. And then when we get back around to it, you let me know what else I think. Yes.
This data doesn't contain age, because otherwise you could just, let's say, focus on people in like the age of the parents, the age range of these, like exclude.
Oh no, yeah, we couldn't get the prescriptions by age, by count. Yeah, but that was something we did try to do. So we can't link them directly to the family, so we're gonna have to rely on this kind of county variation. So any measure relationship that we identify could just be the result of like an unobserved factor that's correlated with high community opioid prescriptions and individual test scores, right? Now, of course, that would still have to be conditional on household benefit receipts. So if they're on food stamps or TANF, fixed effects, county control measures, so all the things you can put in, it's still gonna be a conditional issue. So what the unobserved factor would have to be something outside of those things. It's not just purely descriptive. That said, we know something about the places where these where abuse takes place. We know more about this. So can we use community heterogeneity in the literature to help us add some confidence to a statistical association if we were to find one, right? So we know that there is a lot of information from other research about what types of households have been abusing opioids, because again, it's really about the abuse story, not about the prescription story. And I should mention that we downloaded data from Vital Statistics and just ran a correlation at the county level between mortality for opioid overdose and prescriptions. They're pretty correlated, right? So I mean, prescription is not it's not a perfect proxy, but it's a decent proxy for abuse. Yeah, at least in South Carolina.
Did you also want to use that as kind of like a complementary kind of like treatment, the overdose test, because that's also, it's not just like an outcome, it can also be right a proxy for.
Yeah, and we did have that in one of the tables, and then when we started going through the referee process, it got put to an appendix at one point, and then it just got dropped out. Nobody really. It's pretty noisy. It did show the same thing that you're hinting at. Yes.
I'm way back here. So I know this is published, so let's think about like maybe another possibility, but you could do something very similar to this using the ARCOS data and thinking about the shipments and the MMEs that are going
Yes.
to the counties. And I'm actually thinking about something very related to this, and we can talk later, but that might be another way of getting at this heterogeneity across counties with the intensity of like the high dose opioids that are going rather than just the prescription.
Yeah, and this is really, I think, really interesting because even though the prescriptions have started to come down the last 5 years, the MMEs it's not as clear cut, and so I think that's a good point. So our thought process here was, go ahead, Jason.
Just to say one more sentence because it's just what is already said. The vital stats on the deaths, though, you could have maybe focused on deaths at certain age. Is that right, or is that actually non-public data? Or like we all also said, like it's so infrequent that it might not be useful.
Yeah, I'm trying to think now. So the other problem with this being a paper that was published a year ago, it also means that I worked on it like 2 years ago.
It was like a big test.
I've got the data over there, so I could look at it.
You can get those right.
I'm just worried about, I'm trying to remember if it was super noisy or not, because the samples are going to be
small.
small.
Likely, but you could imagine doing something like having both ages outside of of the ages that have small children, those deaths versus those that do have small children, and ask whether like you're getting a signal from the right ages.
Sure.
I'm just repeating.
So we do other things that are in that same vein, and we do look at the threshold effects that kind of Bobby was starting to get at in the paper too, like looking at growth rates, looking at, is it just the high prescription? Is it, because remember, we're talking about the regression is going to be picking up change, right? But is it the change in the places that are also really high? Because that's where you would expect the abuse to be, and it is where we find the association is driven partly by that. So, and I'll get to it. So anyway, I kind of thought was, all right, we know we got this issue about, unobservable. Can we tried to set up an identification strategy, knowing that it wasn't going to be causal, that was consistent with, do we find consistent evidence with negative spillovers of the epidemic on children who are most likely affected from what we know which communities are affected, right? That was kind of the gist we were taking, right? And so let's talk about heterogeneity of opioid prescriptions and abuse from other literature and some data that I can show you guys, right? So I think one of the most salient aspects of the opioid crisis has been the disparate impact it has had on different communities. We know it's not a homogeneous epidemic, right? And so several researchers have found that the largest effects of the opioid epidemic have been felt among white communities. You know, there's all the deaths of despair stuff from Angus Deaton and all of that research. We know that that prescriptions are highly correlated with white communities. We know that abuse is white communities. We know that there are these different factors at hand. And a substantial literature has also identified that the problem tends to be especially concentrated in rural and or low income communities. And I should say in South Carolina, that's the same thing. Rural communities are the low income communities. Heavily that correlation is going to be. All right, so just to give you guys some other perspective on I know that almost everybody in this room, or I'm assuming everybody in this room is pretty familiar with this, so I'm just preaching here, but there's this paper that came out in JAMA Internal Medicine 2 years ago that I just thought was a really great way of presenting the nature of this relationship. And so here at figure A, we've got opioid overdose deaths. And on the vertical axis, they have zip code level data from the state of California from these 5 years here, okay? And what they have here is zip codes ranked by whiteness. This is the whitest zip codes, the least white. And then on the horizontal axis, this is median income by zip code. So these are your wealthiest, and these are your whitest zip codes, right? And so if you look at the death rate in those areas by zip code, you see a very distinct pattern, right? There is a definite income gradient and whiteness gradient that the overdose deaths get clustered in this upper left-hand corner. They are your low income white zip codes that disproportionately kind of bear the brunt. There's this definite upper left kind of trend. Here in B, it's the opioid prescription prevalence. So it's this kind of prescriptions per capita sort of measure. Same dimensionality. And you see that the gradient isn't quite as strong upper left. It definitely has an upper left feature. It's a little bit more of a whiteness bias, but it's definitely the same kind of idea. And so what we thought to ourselves was, let's just see what it looks like. This is California. Let's just see what it looks like if we do South Carolina. We do the same kind of analysis. We don't have the overdose deaths in this analysis. We just have the prescription rates, but it's the same concept, right? So these are counties, whiteness of the county, income of the county. What do we see? And you get the same kind of upper left kind of feature in South Carolina that you see in California. We're not seeing a dramatic difference between these locations. And I should point out, there's no data here in this most upper left cell because there is not a single county in South Carolina that is in the upper quartile of whiteness that's in the bottom quartile of income. So that's a different paper. So somebody should look at it. Anyway, but it's the same general idea, right? So this basic idea that where we think children are most exposed, what children should be most exposed to this, who have the highest probability that there is abuse happening in their family or their communities around them, it should be white kids who live in rural areas or more low income, right? That should be where the data suggests we should find these outcomes if they are there. So we know that there's this strong correlation between county level opioid prescription rates and county share of white residents. And so white households have a greater probability of receiving or abusing prescriptions. This is consistent with what we see in these data with past literature. Further, greater concentration in rural communities. So we utilize an empirical strategy that capitalizes on our knowledge of the fact that we know what the students' race is, we know where they live, and we can kind of tie it back to these characteristics. So if spillover effects of opioids abuse exists, it should exist predominantly with white students who reside in rural counties. That's our kind of hypothesis going into this. So our methods is, we use many different methods as all applied papers do. Kind of the main table is the student level regression. Let me just walk through it real quickly. Yeah. So the left-hand side Y here, this is the standardized test score for the end of year math tests for students, for a particular student in a particular county in a particular year. And this is in Z-scores, so it's a standardized test, but then we standardize it by grade year so that we can compare the students effectively. And so our outcomes are going to be these kind of standard outcomes that we see in a lot of education type papers, it's going to be like the effect in terms of like tenths, hundredths, or thousands of a standard deviation of achievement. Again, our main treatment here is these opioid prescriptions per 100 people. We're going to lag this a year, so this is going to be the prior year's prescriptions on this year, both to try to account for, we know that there's kind of like this research, trying to remember the paper, that shows how prescription opioids tend to be kind of like a gateway into abusing prescriptions, which then leads to other issues. So lagging effect might make more sense. And then there was another reason which I can't remember.
When you say T-1, so the tests are in May of the year.
Oh,
It's the,
yes, it's the prior year's prescriptions. And that's the other reason. It's the test in May, but all the learning feeds back even into the prior year. And then we've got this indicator for whether or not the student is white or non-white. And so our originally you could just go and say, okay, we'll run that regression with the controls that I'll get to in a second. Beta 1 here, if there's an effect at the community level, would be negative, at least if there's a statistical association. If that beta 1 is negative, then you're saying, okay, the places that have a higher prescription rates this year, next year, we're seeing lower test scores that following May. And then we had this interaction between the white indicator and that prescriptions per 100. And so is there a differential effect with the white students? And again, because we have this individual level data, can we pull out the fact that we would expect beta 3 to also be negative? And then of course, the combination of beta 1 and beta 3 being the kind of combined marginal effect on those kids. Z is a vector of county level controls. So it's things like poverty in the county, unemployment rates in the county, median household income in the county, things like this that we think are associated with lower test scores, and then individual characteristics of the students that we know. So we know, are they male or female, and we can see if they're on SNAP and or TANF at that time. Yeah, bye.
Did you get the proportion that are actually farmers?
No,
They have such a high accident rate.
no, we don't have that. See, I don't know, would that vary meaningfully year to year?
It's certainly vary across the world.
Yes, I agree with that completely. I'm just thinking it probably is just going to drop out or not have a lot of variation. I'm just curious if we could even measure it more than in the 10-year census. Maybe you can. Yeah.
it'd be like the ACS was, on the county level, good enough for,
Yeah. Yeah. No, that's a good point though. As a confounder. Then we're going to include county fixed effects and grade year fixed effects. And then, we do the thing where sometimes you take one out and put county trends in, sometimes you leave them both in, plus there's standard errors. Let's see what we get. So just skip to the results here. There's again the main table. So the first thing we do is just, everybody sees what we're looking at. Here's the prescription treatment lag. Here's a white indicator variable, then here's going to be an interaction. Here's that matrix of yes and no's for all the different combinations we've set up, and then the combined marginal effects for the whites and the non-white students down here. So the first thing we did was we don't use the interaction, just in column 1, we just use grade year fixed effects and county fixed effects, and just run it, just to kind of get a baseline reading. And we get here is, you get the positive association of being white on grades or test scores, so we see that your white students do better, that makes sense. We get this negative association p-values, marginal significance, 0.089. And this is just overall, all students, right? And that was like, we looked at them, like, okay, so it looks like there might be something there. And then, so column 2, we replicate this, but look at the differential effect on the white students. And when we do that, the coefficient now gets bigger. P-value still, again, kind of marginally significant, but we can see that the effect that we're seeing here is being driven by the white students, right, as we would expect. Then at 3, 4, and 5, we add county individual controls, county time trends, etc. And you can see that this effect is pretty stable. When we include the county time trends, the marginal effect kind of drops down, and this will be the most conservative estimate and the one that we track through the rest. Yes?
What's like the average of the RX per 100? Just to.
Okay, so the average is almost exactly 100. So these marginal effects are about 1% change in prescriptions equals about. So I'll get some context on this.
I was just wondering because like what we see is that the prescription effect reduces the inequality between white and non-white students, right?
Uh-huh.
And I was just wondering by how much, like for the average county, right? Like how much has the opioid epidemic,
The average in the time period here is 97 per 100.
let me take it times 100.
It's in essence, we're talking about 1% increase in prescription rates yields this number for white students in terms of an effect.
But it just means not like 1%, but just like what's the typical increase? And I think if you say it's around 100, then it looks to me that it's around like a third or something reduction in the compared to the white main effect.
Yes, it's a pretty big difference between the two groups.
Maybe that's a weird kind of like silver lining or something, but like it did decrease kind of like the racial inequality.
Yeah. Yeah, right.
So.
Yeah. So the white students aren't doing as well because they're being.
Exactly, like the bad way to decrease.
And these are average treatment effects. All right, so I'll give some context on the magnitudes, like should we care about this in just a second. The other thing is because we have some panel nature here where we can track some students for multiple grade levels, we can actually just use individual fixed effects. And when we do the individual fixed effects to get a lot more precision, the size of the effect drops by about 60%. But even within student, which I think is a much stronger association, we do see that there is an effect even within student. Again, it's an average treatment effect, right? So most of these kids are not living in households that are affected by opioid abuse. Most of these kids are probably, if anything, having trivial spillovers in the classroom. So getting a measure of this size suggests that there's probably a small number of kids who are affecting this a lot, potentially, if we believe in the statistical association and really driving a lot of this. Yes?
It's one problem. And none of this is really just like I'm interested in it. Like, could you do some kind of like back of the envelope calculation about, you know, what do we know, like a typical addicted person, how many prescriptions do they consume per month or something like that, or per year? And then, you know, like what share of addicted people might have children? I mean, one could do some kind of back of the envelope, right? Because it's like the intended treatment.
Yes.
When you could get to a number about like what is the effect for the children that are affected.
Right. And so, yeah, I think that's right. We probably would have been a good thing to do.
I mean, there is some balance, but like probably.
Yeah, there would have to be
that's
some.
like that's completely crazy, right?
No, I don't think so. And you know, one thing that is useful, it's not to what you're saying, but it's a different way of kind of thinking about this, is knowing that it's an average treatment effect, is what does the average treatment effect tell us? As we know that, you know, we should probably look at what's the percentage that are actually abusing, and then in that age group, we can just use national data and kind of back that out actually. What we try to think about, at least how we think about the average treatment effects, you know, the education literature, there's this paper, I don't know, you might know it, but this paper by Lipsy, who's in the ed school at Vanderbilt, and there's like a lot of co-authors on this. But translating the statistical representation of effects of education interventions into readily interpretable forms. This is something I think anybody who's ever done anything in education, you're always constantly like trying to get people to, is 2/100 of a standard deviation a lot? Is that not a lot? What is that? And so this paper does a good job of trying to give us a way to think about that. And so I'll just give you one example. So in this paper, they say that national annual achievement gains in math should be about 3 to 5/10 of a standard deviation. So it's about 3/10 in middle school, and it's about 5/10 in the upper elementary school grade. So that's why we say 3 to 5, because those are the years that we're looking at 3rd to 8th grade. And so a 10% increase in opioid prescriptions in our estimates translates to about approximately 2.5 to 4 weeks of learning loss in math. Again, that's the average treatment. Okay, so that's across all the students, where we know that the vast majority are not actually treated or affected by opioid abuse. So I think that gives us some perspective that, you know, maybe the effect on the kids in these families who are displaced, you know, the research says they're displaced from home, they're probably not getting sufficient resources. It could be quite large for those kids. And again, this is more of a motivational paper saying, you know, we're seeing the statistical association with these spillovers. It may be something that's troubling. Other things that we did, which I can just roll through quickly, is, you know, we're looking at county level variation and individual level data. There can be problems with that. So we aggregate up the data. So we're looking at the white students separate from the non-white students and just do the county level at the county level. So this is county level average test scores for white students, county level average test scores for non-white students by grade year. And we just rerun kind of the same estimation. What you see here is the effects that we pick up are all with the white students. We get negative estimates for the non-white students, suggesting that maybe there's something going on in the background, but nothing nearly as large or, well, equally precisely measured, basically, but nothing nearly as large of an estimate to give us any kind of statistical confidence. Next thing we did was we tried to leverage even more of our understanding about the heterogeneity of which communities, which families and communities are likely to be affected, right? And so the literature told us it wasn't just that this is a white situation, it's more of a like rural or low income situation. So we figured, does this group drive the numbers we saw? We would expect it to be this group or this group because we saw that it's heavily correlated with white students, but can we get a difference if we look between urban and rural? And we do. We see that anyway, we see that this is of the four groups where we see it, right? And just taking a step back and thinking about that color-coded grid we looked at, which was just purely descriptive. That grid said white is the #1 driver of those two factors. White was the #1 driver, and then maybe low income, which is rural nature here. And if you look at just the estimates, you see, again, just ignore statistical significance for a second. White rural is where we get the biggest estimate, and then it's white urban, and then it's rural non-white, and then it's urban non-white. And that's very consistent just with those very simple descriptives of what we would say, even conditioning on all these other factors. Now, the last thing we did was, we really didn't know exactly what we would see with this. We now broke it out into 8 groups where we could calculate the marginal effects by just adding more and more interaction. So we've now got the 4 rural groups, white, non-white, receiving TANF or SNAP, not receiving TANF or SNAP, and then the same 4 groups but urban. And again, we would expect, we know that it looks from the prior slide like it's the white rural groups, but here we've got the families where we know they're receiving food stamps or TANF, and here that they're not. And we ran this, you actually found that it was the non-receiving households that the results were mostly being driven by. Now we get a non-trivial estimate here, but it's really here that we were seeing the effect. So this, we don't necessarily have a great explanation. I could come up with many stories, but they're completely anecdotal. But being in South Carolina in a rural county does not mean that you are wealthy. By no dimension is that true. And there may be some other issues, because receiving food stamps doesn't mean that, receiving food stamps definitely tells us something about your income level. Not receiving it doesn't necessarily tell us, because again, it could be a handful of families that are really driving the results here.
This is not received, not eligible.
Yes, this is receipt, not eligibility. So these are, we actually know if they're receiving. It has nothing to do with if they could be receiving. Yeah, absolutely.
Know if they're receiving Medicaid?
No. We only know that they're receiving either TANF or SNAP. We do have Medicaid data, but they wouldn't let us link them for whatever reason. The other thing we looked at was, we looked at some threshold effects, and we did something like where we just looked at the county's growth rate in prescriptions from a base of 2006, which is our first year, and you find that, that it's the high growth, the states that, the counties that, not just that the trend is positive, but that the number of prescriptions is really high that's driving it. It's the kids in the places where the prescriptions are really high rate, which is more consistent with abuse. So you can look at those that are, you can quartile them and look at the ones that are above, or there's a number of different ways that we looked at it, but it was very consistent. It was also, you get more statistical significance in the years that are more consistent with, like if you break up your sample to the earlier years where there's less opioid prescriptions, and the later years where there's a lot more. A lot of it's being driven by the later years where we know there's more abuse. So a lot of very consistent circumstantial evidence is what this paper was kind of presenting. So our motivation was, given kind of these really bad effects of opioid abuse on households, are there potential spillovers onto children? And we think that there probably will be. So we investigated if we could find any evidence of a potential relationship between opioid consumption and children's educational performance. And I shared with you the results that we do find that there is this relationship. It's primarily, we find it among white kids in rural areas in South Carolina, which is kind of the communities we would expect it to be. And so, I think we all recognize that educational success is really important for social and economic prosperity. And the notable reduction in test scores may indicate that there could be long-lasting spillover effects on segments of the population. So we kind of felt like the outcomes of this research suggest future research on spillovers that looked at things like educational attainment, social status, employment outcomes of children who grew up in communities that were exposed to high levels of opioid abuse. You can measure that in a number of different ways. It is probably warranted. That was kind of like was our goal, was did we see evidence that's consistent with this story? And we did find evidence that kind of lined up with where you would think you would. Yes.
So can you try doing something with the characteristics of the schools?
Yeah, so we do have characteristics of the schools. So, you know, on the other paper, we did use the characteristics more than we did here. I think there's ways that we could look into the nature of the schools a little bit. I'm trying to remember if we had sibling things for all the years or not, but there was also some sibling stuff I think we could do. Anyway, thank you guys. Appreciate you listening. And if anybody wants to chat, either at the break or at lunch or any of those times, happy to do so. So thank you guys.